Hi, everyone. Welcome back to Conversations with Therapists. Today I'm joined by Dafna Berman of Krogius Psychotherapy. Dafna, thank you for being here.
Thank you.
To start, can you tell us a little bit about what led you to specialize in trauma and attachment work and what really drew you to this area?
I think I kind of stumbled into it. As I was starting my career, I noticed that there was a common thread among the clients that I was seeing, the clients that were struggling the most. They all had histories of really severe trauma, usually starting in early childhood. These were people that actually had all possible diagnoses except for a trauma-related diagnosis, but those diagnoses didn't really quite capture, didn't quite explain what I was seeing. I just felt inadequate. So I came across an article that was talking about, I think it was Babette Rothschild, that talked about the body remembers. And that was an era where cognitive behavioral therapy was very dominant in the field, psychodynamics. And so the concept that the body is involved, there's something going on with the body, kind of piqued my interest. Also, it sounded like an oxymoron. Well, how can the body remember, right? Because we remember with our brain. I kind of started looking into that and considering what happens where there's trauma in childhood. It usually does involve the body, right? When children are abused, often they're either physically abused or their physical needs are neglected. That happens during the formative years where we usually don't have a lot of memories from our childhood. So it kind of made sense to kind of start going down that path. And that also then coincided with the whole field, kind of recognizing that there's more than meets the eye when it comes to how we understand trauma, and then not all types of trauma are not all created equal. My interest came more from trying to understand, get a deeper understanding of the people that I was working with and what was going on with them and what were they trying to tell me, right? So there was a story there that they were having a hard time articulating, right? There was a very emphasis on the why. I just felt that what I had learned up to that point was not sufficient. And I think around that time, also ACE studies came out, which was the adverse childhood experiences, and the field in general recognized that childhood trauma is much more prevalent than we had previously acknowledged. And they started validating the connection, which I saw in my practice, that the history of childhood trauma did lead to chronic and complicated physical conditions later in life. The other thing that was going on is many of the clients that are labeled, quote unquote, difficult. I don't know if I had more patience than the average therapist, or I was willing to put up with more extreme behaviors than the average therapist. So I did find myself with more and more clients that, have either walked away from previous therapists or the therapists just felt were too much. Ever since I was little, I was trying to understand, why are people the way that they are? Why are people doing the things that they're doing? When things don't make sense on the surface, then we go in and kind of start to peel the layers.
There was one line that you said that stuck out to me a lot, which was that trauma looks different on everyone. That leads me to my next question, which is many people who you work with are high functioning on the outside, but are struggling internally. What are some signs that someone might be carrying unresolved trauma or attachment wounds, even if their life looks together or normal?
The life might look together and normal on the outside. The person who's living the life doesn't feel that things are together, right? So people have the imposter sense, right? That what people are seeing on the outside is not who I really am. And then there is a concern, well, if they find out who I really am, then that's going to be a problem. The lived experience is such that you feel that there are more than one of you, that you're being pulled into different directions, and that you sometimes make decisions or do things that you then wonder, well, what was I thinking, right? And you can't explain. And that's usually an indicator that there is more than one of you, not in a pathological sense, right? We all have parts, any given moment, there's a part of me that wants to do this, and then there's a part of me that doesn't want to do that. But with trauma, our parts become more separated from each other because we have to compartmentalize the traumatic experiences. We become invested in the parts not knowing about each other. And so they become an independent agent, so to say. And sometimes part of us might act in a way that they perceive is in our best interest, or they're trying to protect us. Other parts see things differently and have different agendas. And so that's when we start feeling like we're self-sabotaging, right? So the sabotage is a very judgmental term. It implies negative intent, but that's what we do in psychotherapy. We befriend our parts, and we learn to see things from their perspective. And we realize, well, from their perspective, it makes sense. It's just that we have access to information that the parts don't have access to. And often the parts have access to information that we don't have access to. And so as we get to know those parts and where they're coming from, the parts kind of learn to work together as a team, as opposed to independent agents working against each other. Appearance of having it all together, that actually takes a lot of energy to keep up that appearance. Usually the person does not feel like they have it all together, right? The subjective sense is that everything is going to fall apart at any moment, or that people are going to find out who I really am, or that there's a sense that you don't understand why people are seeing you the way that they do, or experiencing you the way that they do. For example, people might refer to you as an expert, or as a leader, or talk to you or about you in positive terms, and you cannot see that in yourself. That's usually an indicator that there's fragmentation.
What you were speaking about with the parts work, it brings me to my next question, which is your approach, which integrates a lot of different modalities, things like somatic therapies, internal family systems, which you just spoke about, neurofeedback, and a lot more. How do you think about choosing the right approach for each client? And do you ever have clients that are just purely one modality, or you always have some sort of combination of modalities when you're with a specific client?
One thing that comes to mind is something that Professor Ruth Lanius says. She's a brilliant psychiatrist and neurologist, and I've been following her research, and she's talking about the need for precision psychiatry, or like for precision psychotherapy, right? Like we have in precision medicine. Because people are so different, what works for one person is not going to work for someone else. But also what works for a person is also specific to time and place and context. So she talks about we have to figure out what works for whom and when, especially when then we were talking about parts, right? When we are blended with different parts, different things are going to work for our different parts. My clinical skills are like a toolbox. I like to have as many tools in my toolbox. And sometimes people will come because they've heard of a modality, and maybe they've tried other things and nothing worked. And so they'll say, well, I want to do this. I respect that, and we go with that. Or I might introduce a concept that's from a different modality. I would say it's person specific and then situation specific for each. Ultimately, it's like cooking in the kitchen, right? You can take a class in Chinese cooking, and you can take a class in Mediterranean cooking and Italian cooking, but you change, right? As we learn things, we change. That affects how we do things. And so you might cook a delicious dish that is just a little bit of all the different cuisines that you've been exposed to.
I've been noticing, maybe it's just pop culture and social media, but I feel like people overuse the word traumatized a lot, and trauma, and just sort of throw it around, meaning sometimes it really is a traumatic situation, or a person is traumatized. But how clinically do you differentiate between someone who has gone through an actual situation in which trauma-focused therapy is necessary versus just CBT or something else that isn't trauma-focused necessarily?
CBT, for example, looks at the connection between our thoughts, our emotions, and our behaviors, right? So that is a way to conceptualize. We use metaphors to conceptualize reality, right? Because that's just how we perceive reality, through metaphors, and that's how we communicate. And so sometimes that's how they approach their experience of the world. That terminology might be helpful to talk to them or to help them understand something that maybe traditionally doesn't call for CBT. The definition of trauma as it is in the DSM right now is a little bit problematic because it implies that there has to have been an incident or something happened. When we look at early life trauma that happens before we're even verbal, right? So as for infants and toddlers and the relational aspect with caregivers, where there is neglect, right? That is traumatic for a newborn or young child, but the definition of something that happened is not helpful, and it's also not helpful for clients who are clearly their system is traumatized, but they can't point at something that happened. A great therapist called Ruth Cohen, she talks about the trauma of neglect, where nothing happens, right? So there is nothing. You're not getting attention. Your needs are not met. Nobody's communicating with you. And when you are a baby, that is traumatic. Really, the trauma is not the event that happens, because we see people who have experienced a similar event or had a similar experience and they don't develop post-traumatic symptoms, right? So it's the trauma is what happens inside, right? Is how does our nervous system respond to what's happening or to what is not happening, right? To the absence of something that should be happening and it's not happening. And so what's happening inside our nervous system, and to what extent is our nervous system able to reset itself and come back to a state of equilibrium, or are we stuck experiencing the trauma as happening now, even though it happened a long time ago? But our nervous system doesn't know that, right? And so in terms of using the popular culture use of people saying they've been traumatized, I think it is important to acknowledge that the trauma is much more prevalent than we would like to acknowledge, that it is a public health problem. I think sometimes we confuse between being triggered and being traumatized, right? And so let's say someone says something that's very upsetting to me. It's upsetting to me not because I'm being traumatized by what they said, but it's triggered an unprocessed trauma memory. And once it's triggered, it feels like it's happening now, because the unprocessed trauma is remembered as happening now. It's remembered by a part of the brain that doesn't have past or future. Everything is now. We remember feelings by feeling them. People will often say, well, that was traumatizing, where really what happened is that a traumatic memory was triggered, and it feels like it's happening now.
Interesting and important distinction, because that's also like triggered is also used a lot. And that was a really powerful line that you said about we remember feelings by feeling them.
Right. As opposed to the more narrative types of memories where we remember them as a story, right? I went there and then this happened, and we might even say, and I felt such and such, but we're not feeling it that way because it's been processed and it's been integrated into our narrative memories of being traumatized that have not been processed and integrated. They're just remembered by a different part of the brain. Sometimes we have these intense feelings that come seemingly out of nowhere, but that is really a form of a memory. We don't know the story that goes with the memory, but we're feeling the feelings, and that actually the ability to separate between emotions and the details of the event is an important piece of what allows us to survive traumatic experiences. Right, where the emotions and the story of what happens are compartmentalized and held apart from each other so that we can go on and function in everyday life. And so sometimes people with serious trauma history, they can talk about horrible things that have happened to them and they don't feel anything. Right. Well, that's because the feelings have been separated and they exist independently, right? And so when people have these intense feelings, it's it's kind of the opposite of talking about horrible things without the feelings. It's now we're feeling the feelings of the horrible thing, but we don't have the story that goes with it. And so we say that it doesn't make sense.
To wrap up, for someone who's watching who might recognize themselves in what you're describing, but feels a little bit stuck in survival mode, what would you want them to know about therapy, trauma therapy, and the possibility of healing?
I want you to know that healing is possible. It is possible. It is hard work, but it is possible. The being stuck in fight or flight mode, that is what your nervous system has learned that it needed to do to survive. So the job of the nervous system is to keep us alive. Right. And if the nervous system has learned that it just needs to stay in fight or flight mode, then that's what it's going to do. What we do in therapy is to kind of help update the nervous system and to kind of learn to recognize that there is some safety in the presence. There might still be threats, but there's also safety in the presence, and to kind of improve the flexibility, right? So it's not that we want to get rid of the fight or flight state, because we all need it to survive, but we want to have more flexibility where we're not stuck. We can come back to a sense of safety, and then if there is a threat, we can go back to the fight or flight as needed.
Really important for people to know that they're not stuck. It's possible, but like you said, it takes a lot of hard work, and I'm really excited for whoever's listening to this to know that you're there for when they reach out, to learn more about all the amazing work that you do. And thank you for being here today and for sharing so much about the important work that you do.
Thank you.